Thank you very much. Thank you, Farid, for the very kind introduction. Uh, I know that Dr. G and Dr. Atik, they've talked at length with the anatomy. I have some slides which I'm going to skip them because obviously, the classification that we have there is from 1926, according to Dr. G, and it's not really applicable now. So, you know, as a pulmonologist, we know a little bit about hiatal hernia or acid reflux as it, there's association with lung disease. We took lectures in medical school and we did some few lectures in internal medicine, and that's about it. So I don't remember having a lecture as a, pulmonary fellow as to the importance of hiatal hernia. And then we look at tons of CT scan. Myself and my partner, Dr. Fred Ume, that is going to be talking to us about the postoperative management of this patient. What I would like to share with you today is my experience over the last 6 years or 7 years since Dr. G came to Celebration. When he first arrived, over this course of time, we've taken care of hundreds of patients with hiatal hernia. At first, we were seeing them just for postoperative evaluation, and then we also took care of these patients in the postoperative ICU and also on the floor. I've never looked at it as a pulmonary disease, but with time, patients will come into the office, apart from their GI symptoms, which majority of them have, they will also complain of, palpitations. Some of them complains about weakness and tiredness. Some of them complains about shortness of breath. And then we see them in the postoperative care months down the road, and the patients will tell you, I feel much better. My shortness of breath is gone. Because we've always assumed that for those patients with giant hiatal hernia, the mechanism of their shortness of breath is related to the size. And so when you see an hiatal hernia that is not really affecting the lung volume, we've always felt this patient is unlikely to be having shortness of breath from it. But over the last few years, I think my view about this have changed, and I'm going to share some of this with you. So I'm not going to belabor you with all this because I've talked about this at length. So, the epidemiology, the sliding is the most common. The paraesophageal, less than 5%, and it's responsible for majority of the patient that we see, because of the size, the type 3, the type 4, that has the big chunk of the stomach and sometimes some of the intra-abdominal organs in the chest cavity. Obvious risk factor, obesity. Also a big one is age. As we get older, at some point, we're all going to develop hiatal hernia. If you look at people older than 50 years old, almost 60% of them will develop it. The definition of giant hiatal hernia, differs depending on which paper you look at. Some people look at the size in terms of, if it's greater than 5 centimeter, whether the 5 centimeter is endoscopically or 5 centimeter is based on looking at the size on a CT scan on the chest X-ray, is not clearly defined. But I love the definition that is based on the percentage of the stomach that herniated into the chest cavity. So they say if at least 30% of your stomach is within the chest, the patient will qualify to have a giant hiatal hernia. I'm going to skip through all these since we've talked about it. But from a pulmonary standpoint, I think the type 3, the type 4 are the ones that, really we get excited about, because we can see it on the chest X-ray, we can see the size of it, we can see the lungs compress, we can see the movement of the heart being pushed to the other side. And in our mind, we've always felt if a patient comes in complaining of shortness of breath, and they have a big hiatal hernia that we could appreciate on the chest X-ray on a CT scan, then, we feel like maybe this patient needs to go for some kind of surgical repair. But obviously, that is not the the full story. So there are more to it than just looking at the size. But again, I think it suffices at this point to know that there are type 1, 2, 3, and 4. So I'm not going to waste much of your time. I'll just skip through it since Dr. G talked extensively about the types, and I'll just move into the complication. So this is what a typical chest X-ray looks like. When we see this, we get really excited. The patient comes to us, whether they have cough, or whether the patient have asthma that is uncontrolled, or whether the patient have some shortness of breath. We could see it, the airflow level, in the retrocardiac region. And then, the patient likes to see that too. Say, yes, you have part of your stomach in your chest. So part of the signs, gastric bleeding, Dr. Atik talked about it, obstructive symptoms. Sometimes they could develop gastric volvulus, strangulation, like a patient that I saw actually yesterday, coincidentally. They could have perforation, they could have ischemia, and then most commonly, majority of these patients will have some form of gastroesophageal reflux. So when you look at the complication that arises from the hiatal hernia as it relates to pulmonary disease, there are those that are related to reflux itself, and there are those that are related to the presence of the hiatal hernia, independent of whether there's reflux or not. When you look at those associated with reflux, laryngopharyngeal reflux is very common. Patient comes in with chronic cough that you've treated them for asthma, post-nasal drip, and all they have is just some form of silent reflux. And that's the reason they have this globus feeling of something, a lump at the back of their throat, that they always feel like they have to cough all the time. Majority of the time, the cough could be dry or non-dry, but this is something that you have to think about sometimes. And surprisingly, majority of them would not have, they won't complain of any heartburn. They have no pain at all. So the absence of pain shouldn't dissuade you from entertaining this possibility. Hoarseness with laryngitis, patient with uncontrolled asthma, they're taking their rescue inhalers frequently despite being on adequate standard therapy for asthma control. It's always important to evaluate them for the possibility of silent acid reflux. There's also an association between obstructive sleep apnea and acid reflux, as well as patients with recurrent pneumonia. When you look at the pulmonary complication, shortness of breath is the big one there, and I will talk more at length about the mechanism of the shortness of breath. Atelectasis is common depending on the size of the hiatal hernia, if it's pushing on the lungs. Obviously, restrictive lung disease from pulmonary compression. And again, there's pulmonary fibrosis from those patients with recurrent aspiration. Whether the aspiration is responsible for it or whether it just contributes to the progression is still debatable in the literature. And then there's the history of the patient that presents with recurrent pneumonia. So when you look at the mechanism of shortness of breath, for years we've always thought it has to be the size of the hiatal hernia. If they come in with their stomach in their chest, some of the intra-abdominal organ like the type 3 and the type 4 hiatal hernia, I think we do a pulmonary function test, their lung volume is compromised, their FVC is reduced, then you make a case that part of the patient's shortness of breath is related to the intra-abdominal organs that are malpositioned into the chest cavity. Again, if they have atelectasis, you could make a case if half of their lung is compressed. And then there's a compression of the left atrium, which is entirely new. It's something that I did not know anything about until the last 6-7 years after I started working with Dr. G closely on some of these patients. And then the compression of the IVC, and patients just complaining of tiredness all the time. And then they tell you that, after I've eaten, I just feel tired. We've always felt, if you eat and you feel like you need to take a nap, it's fine. But I'm not talking about postprandial sleepiness, but postprandial tiredness. They just feel fatigue, And sometimes it's just reduced venous return going back to their right side of their heart just because of the distension of the stomach. And then when you look at the cardiac complication also, this is also new, to me, in particular in the last 6 to 7 years. This is nothing that I was taught as a resident or even when I was going through my fellowship. And then some of the patients that we've seen over the last 6 years that have palpitation, that have, recurrent atrial fibrillation, that they have to be cardioverted frequently. And then they go in for hiatal hernia surgery. And the patient comes back, and then you see that there is a strong correlation and says, since my repair, my palpitations just disappeared. And also, I've not been cardioverted, So I started looking into it. I said, is there a relationship between these? And surprisingly, I will share some of those with you. Then the issue of the left atrium compression, I have some slides to show with you, to share with you also, and how that could account for some of their shortness of breath by the increasing pulmonary venous hypertension, because the pulmonary vein returns back to the left atrium. If there are compression of either the pulmonary vein or compression of the left atrium, it reduces the blood flow back to the left atrium, thereby could lead to some form of pulmonary edema, or just not frank pulmonary edema, but the physiology of pulmonary venous hypertension resulting in shortness of breath. Angina pectoris also. A most common cause of chest pain is actually, GI. It's not the heart. Obviously the GI one won't kill you majority of the time. So when somebody comes in with chest pain, we're always worried about the cardiac origin of their chest pain, because you could die if you have a CAD that is undiagnosed. But surprisingly, there's a mechanism from patients with reflux, whether it's the esophagitis, whether it's the irritation of the pericardium with the position and the compression of the hiatal hernia on the surface of the heart, resulting in some form of inflammation, vasospasm of the coronary blood flow, resulting in angina pectoris. I think there's a lot of hypotheses there, nothing definite at this time. And then there's issue of cardiac tamponade also, depending on the size of the hiatal hernia. So this is an example. The A is a normal coronal view of the CT chest, where you can see the heart very well, see the left atrium, the AV groove, you see the coronary sinus, you see the position of the esophagus there, and then behind it is the aorta, and in front of the esophagus also, you see the IVC. And then on the B, you could see a patient with a giant hiatal hernia, and the closeness of these to some of the cardiac structure. The position of the left atrium that is being compressed. You could see the effect on the coronary sinus. And also, depending on if it's a little bit more to the right side, might also compress the IVC also. And this is a nice picture of a patient. The A is a preoperative. The left atrium is squeezed. And then you look at the postoperative on the B side, where the hiatal hernia has been repaired, and now the left atrium, you could see that it's a little bit fuller in terms of the blood flow into it. The B side is an echo. You do an echo, you do a lung parasternal view, where now the left atrium is all the way down posteriorly. And postoperatively also, you could see that there's more filling into the left atrium compared to the echocardiogram with this in C, whereby the left atrium is compressed. And if you do a 4-chamber view of an echo also, the structure on the right side, on the left side are the right side of the heart, and the structure on my right are the left side of the heart. And you can also see that the left atrium appears to be compressed compared to the postoperative period, whereby the left atrium is fully expanded. This is a picture I saw online, so I decided to share it. A patient that presented with recurrent non-ST elevation, myocardial infarction, and had a left heart cath with normal coronary vessels, and EKG looks abnormal. Cardiac enzymes were slightly elevated, and this is just an example. The patient was actually in shock. This is a large, hiatal hernia that appears strangulated and obstructed with a cardiac tamponade physiology. So what about the mechanism of the atrial fibrillation? If you look at the prevalence of atrial fibrillation, it's about 1 to 2% in general population. The older we get, the higher the chances of developing this. If you look at patients with hiatal hernia, the prevalence is higher. The mechanism of it is related to both the reflux and also to the hiatal hernia. If you just take patients with reflux without hiatal hernia, the incidence, the prevalence of atrial fibrillation is increased. When you have both together, it's even higher. And there are tons of studies that have shown the resolution of atrial fibrillation, especially in young people with repair of the hiatal hernia. So this is just, a little bit cartoon that I pulled there to explain the mechanism. There is the autonomic activation because of the position of the left atrium, very close to the periesophagic blood flow as well as nerves. There could be an esophagic cardiac reflex. There's a closeness to the vagus nerve that can also cause arrhythmia. And then there is the direct irritation of just the hiatal hernia pressing on the heart itself. And then this is another study that I want to share with you, a paper that was published in 2016 by Bala that took patients with hiatal hernia, looking at patients with GORD and about 502 patients with gastroesophagic reflux, and divided them into those that has hiatal hernia compared to those without it. And you look at the prevalence of atrial fibrillation in them. The patient with hiatal hernia, the incidence of atrial fibrillation is higher compared to the patient without it. And also, when you look at it in terms of the size, the larger the size of the hiatal hernia, the higher your prevalence of atrial fibrillation. This is also another study from 2013 by Ragini, where over a 30-year period, they took over 100,000 patients diagnosed with hiatal hernia, and they look at the prevalence of atrial fibrillation. About 8,000 of them have atrial fibrillation, which is about 7% of that population. And you remember that I shared with you that the prevalence in general population is about just 1 to 2%. So when you look at patients with hiatal hernia, the prevalence of atrial fibrillation tends to be higher. This is another study that looks at the prevalence of atrial fibrillation with hiatal hernia compared to general population. The blue bar is the patient with hiatal hernia, and the red bar are the patient in the general population without it. When you look at it, irrespective of your age, the presence of hiatal hernia increases your probability of having atrial fibrillation. The A is the male, and the B is the female. And likewise, when the presence of hiatal hernia increases your probability of having atrial fibrillation irrespective of your age. But interestingly, I just want to share this. It has nothing to do with the slide, but I find it very interesting that if you have atrial fibrillation, we know that most of those patients, they are survivor in terms of development of stroke, in terms of development of congestive heart failure, and in terms of overall survivor, tends to be a little bit worse than just, normal people without any atrial fibrillation. But if you have a hiatal hernia with atrial fibrillation, for some reason, it reduces your chances of having bad outcome. And I don't know why. And I look everywhere and I couldn't find out why. So I just, so it's one of those things that on one hand, if you have hiatal hernia, you have a higher chance of having atrial fibrillation. But if you're going to have atrial fibrillation, I think it's better to have it with hiatal hernia because it prevents you from dying from it. And then I'll finish up by showing some slides with idiopathic pulmonary fibrosis. When we look at the CT scan of patients with pulmonary fibrosis, majority of them will have hiatal hernia on the CT scan. And then we always question all our patients with pulmonary fibrosis for the presence of reflux, because we know that undiagnosed or treated reflux contribute to the progression of the idiopathic pulmonary fibrosis. Again, whether the presence of the silent reflux is responsible for the pulmonary fibrosis is still not well known, but we do know without a fact that if you have pulmonary fibrosis from any other cause or any reason, the presence of acid reflux going down into your lungs will make the disease to be worse. This is a nice study where they took patients with 3 common pulmonary diseases. They took patients with IPF, patients with COPD, and patients with asthma, and we look at, on a CT scan, the probability of finding hiatal hernia. In patients with IPF, about 39% of them, you could see, a well-defined hiatal hernia on their CT scan compared to patients with asthma or COPD. So again, this is just to buttress the fact that patients with pulmonary fibrosis tend to have hiatal hernia more than the other respiratory disorders, and we should look for it and we should treat it because it's possible that it's contributing to the etiology of the disease, but definitely it will contribute to the propagation or the progression of the disease. So it has to be treated. And then if you have it with IPF, your mortality is a little bit higher. So this is the study from that was published out of Emory, where they took patients with IPF without hiatal hernia compared to those with hiatal hernia, and the mortality is higher. So I finish up here. So I've been able to share with you that the size of the hiatal hernia, definitely the bigger it is, the higher your likelihood of having some form of pulmonary compression or cardiac compression. But the size does not explain all the symptoms. The compression, it might be a small hiatal hernia that is not giant, but depending on the location and what structure is being pushed or compressed, that might also explain some of the symptomatology of the patient. I will stop there. Thank you very much.